Good morning, Dr. Regis. I'd like to discuss with you Miss Divine Pearl in room 431. I agree that she is in need of treatment for her preterm contractions and with complications, including a history of a 32 and 34-week delivery. I believe the proper plan of care for Miss Pearl includes to admit her for further testing and treatment, with my anticipated plan of care being to discharge her home after we have completed a transvaginal ultrasound showing a cervix that is longer than 2.5 centimeters, as well as a negative fetal fibronectin result. Currently, she cannot have a fetal fibronectin done because she's had a vaginal exam, digital exam, done since arriving to the hospital. While at the hospital, I would put her on continuous fetal monitoring and contraction monitoring and order a BPP as well as the transvaginal ultrasound for cervical length. For lab work, I would order a complete blood count, a chemistry panel, and a CRP to determine if she has a possible infection. At this time, I will not recommend to start vaginal progesterone because we do not know a cervical length. However, if she does have a cervix that is shown by ultrasound to be 2.5 centimeters or shorter, then I would recommend starting vaginal progesterone at home because she has a shortened cervix and a history of 2 preterm births. Tocolytics is a interesting subject for Miss Pearl. I would start tocolytics as a PRN medication at this time to stop the preterm contractions because although on digital exam we know she's closed and long, I don't really know quote unquote what long is. And so I'm not sure if she's meeting that 2.5 centimeter requirement or not. And I don't have fetal fibronectin results. So, and those are the two things that are used to determine if preterm labor plan of care should be medication and hospitalization or home. So at the current time, I would order nifedipine, also known as Procardia, 20 milligrams orally times 1 now, and you may repeat every 20 minutes for a total of 3 doses as needed for painful contractions. If the patient is showing contractions on the monitor but is no longer feeling the contractions and they palpate mild to the nurse, then there's no need to give further doses of Procardia. I also do not believe that at this current time there is a need to start magnesium sulfate therapy because she is closed and thick, her cervix. I would say that if I'm unable to stop the contractions with the painful contractions with the Procardia and have to start a second tocolytic, then I would also consider starting magnesium sulfate therapy for at least the first 24 hours while we wait to get fetal fibronectin results to be able to test and get results for the fetal fibronectin for neuroprotection of the fetus, not to stop contractions. I would also make sure that her care staff understands that she's not to receive the Procardia at the same time as the magnesium sulfate. If I had to start magnesium sulfate, I would start with a 4-gram bolus to be given over 20 minutes. And then I would do a maintenance dose of 2 grams an hour with a initial, well, we already mag level we'll have from the one. So with a mag level every 6 hours or as needed PRN for signs of mag toxicity. Betamethasone, I would give that as our antenatal corticosteroid of choice in Nevada, and I would order that 12 milligram injection to be given IM now and repeat in 24 hours so that a total of 2 doses is given. And this would be used to help decrease neonatal mortality rates and respiratory distress syndrome in the neonate if preterm delivery was to occur. Furthermore, I do not believe that at this time Miss Pearl needs any antibiotic therapy because ACOG says that preterm labor is not stopped or helped through antibiotic therapy as long as her membranes are intact. She's not showing any signs of an active infection elsewise. She does not need to be treated with antibiotics, and we need to ensure that we are doing antibiotic stewardship, and I would not start that. I would also consult the patient's maternal fetal medicine doctor. Miss Pearl is high risk because she already has a history of a 32 and 34-week delivery, so she should already be seeing a outpatient, like outside of the hospital, maternal fetal medicine doctor. So I would call them, whichever doctor's on call for the shift, and ask them to come consult with us on Miss Pearl. Now, my plan of care would be after the 24 hours, the contractions have stopped. We know that her cervix is greater than 2.5 centimeters. Her FFN is negative. Miss Pearl will go home. And go home not on medication. She will be instructed to follow up with her provider, me, within 1 week, 5 to 7 days, and she'll also be instructed to follow up with her high-risk doctor in the same amount of time unless they request a sooner time frame. She'll be instructed to return to the hospital for decreased fetal movement, vaginal bleeding, with the education that some slight spotting, pink discharge, or spotting may occur for the next 24 hours or so because of the digital exam and transvaginal ultrasounds. She's also will be instructed to return if her water breaks for decreased fetal movement or 5 or more contractions noted per hour that are painful and occur over a 2-hour time period. Now, Dr. Regis, I'd like to discuss with you your plan on sending Miss Pearl home on complete bed rest. While I understand that that has for a long time been the routine standard of care for preterm labor patients, I'd like to discuss with you the fact that ACOG, as well as the Society for Maternal Fetal Medicine, 2016 for ACOG and 2020 for the Society for Maternal Fetal Medicine, do not any longer recommend bed rest or activity restrictions in patients with preterm contractions or a threatened preterm delivery. In fact, a study by Levin et al. In 2018 found that 37% of women who were put on bed rest interventions for preterm labor delivered preterm, while only 14% of women put on preterm who weren't put on preterm restrictions delivered early. So almost twice as many women who had experienced preterm labor contractions when put on bed rest delivered as those who were not put on activity rest. It further explains ACOG, Society for Maternal Fetal Medicine, and Levin also further explain that putting patients on bed rest has negative effects for both the mother and the fetus. One negative effect for the fetus is an increased rate of preterm delivery, as well as small for gestational age weight. For mother, we've got issues as well, and they include deconditioning, venous thromboembolisms, bone loss, and increased stress from not being able to work and or from being bedridden and not being able to care for the house, care for her children. So for those reasons, Dr. Regis, I believe that we should do the plan of care and send the patient home who's just had preterm contractions and not preterm labor or a threatened preterm delivery. And we should send her home with just the normal labor precautions and the return within 5 to 7 days for us, and the return within 5 to 7 days with maternal fetal medicine, unless they request a shorter time frame. Thank you.